Hello, everyone. Thank you for joining us. We're just going to give a moment for others to get connected. Hello, everyone, and welcome to our ISPCAN Prevention webinar series. ISPCAN International webinars are always free of charge and cover diverse topics and programs, which are presented by subject matter experts from around the globe. These 90-minute sessions are designed to help you, our members and partners in the ISPCAN community, gain access to knowledge and expertise to inform care, improve practice, and drive policy change. All this critical to help improve outcomes for children globally. We are very excited about the month of November as it marks our ISPCAN annual Child Abuse Prevention campaign. This campaign is 19 days of highlighting the great prevention programs of our ISPCAN country and international partners, our members, and our colleagues. It's 19 days of providing cutting-edge, open access prevention resources on our website and throughout social media. And we want you to join us in this campaign. Please use the hashtag #RiseUpToEndChildAbuse to share a resource with us. Help us work together as a global community to share multidisciplinary tools, programs, resources, and best practices to break down silos of knowledge. During this prevention campaign, we always host 3 webinars. Last week, we hosted Breaking Barriers with Song, the global impact of the My Body is My Body music program. The recording of that session is available on our ISPCAN website in the Knowledge Hub under Webinars. And next week, from our colleagues at the Smile of the Child, we'll focus on understanding and responding to children who run away from home and institutions, highlighting the cutting-edge RADAR program. And of course, today we are so excited to partner with our colleagues at Eliza to focus on the value of multidisciplinary approaches to child abuse prevention, best practices, and sustainable applications from Greece. Tips for making the most of today's session? Just please engage with us. This session is meant to be an active, interactive learning platform. Please participate by sharing your comments in the chat and your questions in the Q&A box throughout the webinar. We'll begin the open Q&A session immediately at the conclusion of the presentation, so having your questions ready and available is very helpful. Please take a moment to introduce yourself to other attendees, our featured presenters, in the chat box. Let us know that where you're joining us from, your organization, and your discipline. We want to get to know you. To enhance your experience, you may enable closed captioning from your Zoom control bar by choosing captions. And as always, for joining us today, a recording of this session and the panel discussion, plus all presentation slides and links to featured resources, will be sent directly to you after the webinar, as well as the certificate of attendance. Our key learning objectives for today's session is to disseminate valuable insights and practical experiences from the Child Safety Care Unit in Greece, empowering healthcare professionals with a deeper understanding of creating child abuse prevention systems. To highlight how multidisciplinary collaboration can be a key factor in the success of child abuse prevention efforts, particularly within hospital settings. And to equip you with practical knowledge, tools, and best practice to support child abuse prevention efforts within your respective roles and communities. And now let's meet our presenters, all of who are affiliated with our partners at Eliza, the Society for the Prevention of Cruelty to Children in Athens, Greece. Dr. Tina Apergi. Dr. Apergi is a clinical psychologist with a specialty in family violence and child abuse. She's an associate professor at the American College of Greece at the Department of Psychology. She works as a private practitioner, contributes as a consultant in school settings, and presents workshops related to issues of child protection, child abuse prevention, and capacity building in professionals working with children. Tina is a consultant with the Justice Initiative in Europe and Greece, which is an initiative calling on the European Commission to propose laws protecting children from abuse and providing restorative justice to adult victims of child abuse. In 2016, she began to collaborate with Eliza and joined its scientific board in 2022. As part of this collaboration, she coordinates the Child Sexual Abuse Prevention Program, Safe Touches, and is the head supervisor for Eliza's helpline that assists professionals working with children in recognition and reporting of abuse. Dr. Alexandra Soldato. Dr. Soldato is an associate professor of pediatrics at the University of Athens Medical School. She's also the director of the Child Safety Care Unit of the Department of Pediatrics at the Children's Hospital of Athens. She has coordinated the replication of the clinical child safety care model, leading to the inauguration by Eliza of this unit and 3 additional care units in Greece. Alexandra supervised these national education programs conducted by Eliza in collaboration with all university pediatric departments in the country and over 7,500 participants. She's a fellow of the American Academy of Pediatrics and scholar member of the Ray Helfer Society. She's also a member of the scientific committee for Eliza and has published 73 articles in international journals on general pediatrics, pediatric immunology, and child abuse and neglect. Also joining us today, Dr. Alexandros Panos. Dr. Panos was born in Athens, Greece, and completed his studies at the Medical School of Aristotle University in 2009. He specialized in pediatrics at the Second Pediatric Clinic at the University of Athens Children's Hospital, where he obtained his pediatric specialty title in 2018. Since then, he's been working as a pediatrician in the Child Safety Care Unit of the Second Pediatric Clinic at the University of Athens, and is also a scientific collaborator of Eliza. He's a PhD candidate at the Medical School of the University of Athens with a research topic on early detection of risk factors for child safety. His specific interests include promoting child health and safety, social pediatrics, and the prevention and intervention of child abuse. And finally, Dr. John Leventhal. Dr. Leventhal is a professor emeritus at the Yale School of Medicine. He's been on the faculty in the Department of Pediatrics since 1979, and for 37 years, he directed the Yale Child Abuse Prevention programs. His research has focused on the epidemiology of child maltreatment, perinatal risk factors for child maltreatment, distinguishing accidental from abusive injuries, and the prevention of abuse and neglect through intensive home visiting. He's published over 200 articles, commentaries, and chapters, and for 6 years, he served as the editor of the Child Abuse and Neglect, the International Journal. He's received many awards for his teaching, mentorship, and clinical care, including the 2012 ISPCAN C. Henry Kemp Memorial Lectureship. In 2015 to 2017, he served as president of the Ray E. Helfer Society, an international society for physician leaders in the field of child abuse. And now it's my honor to turn the session over to our presenters.
Hey, good afternoon from Athens, Greece, to everyone that I have been seeing joining for the past 5 minutes from literally all over the world. I'm Tinia Pergi, the first presenter from Eliza's team, and just listening to everybody's work once again, although we all work together, feeling really strong in working out there with such a great team on child protection and prevention of child abuse. So my presentation will try to showcase really the value of multidisciplinary approaches to child abuse prevention and show some best practices or what we consider best practices and sustainable applications of this multidisciplinary approach here in Greece. I'm going to start with a little bit of more theoretical stuff, not so much data-driven, but mostly to create a context of what we mean and what we understand when we say multidisciplinary approaches. The truth is that different countries really tackle the problem of child abuse prevention according to their understanding and their capacity, and team works, different teams work very differently according to different countries, again, and regions and cultures. One thing I wanted to highlight, just looking at the literature, is that it seems that upper and upper middle income countries have a much more well-established child protection systems that tend to be multidisciplinary, whereas up to now, research shows that lower and lower middle income countries usually have more fragmented approaches to child abuse, single stakeholder approaches that don't really, I guess, help in creating a preventive web for children. So as we're going through the different models and the different factors and the different specialties that can contribute to multidisciplinary approach, it will be good for people from different regions of the world to really think about what are the key challenges in your country, and what could be an effective response to violence against children from your perspective, and especially what you think is lacking from the systems that you have in your countries. That would definitely contribute to discussion later on during the Q&A. So let me move on with my slides. So let's see how the different sectors can contribute. When we talk about integrated efforts to prevent child abuse, what do we mean? What are the different sectors that can actually play a role, and how can we integrate them? So let's start with public health initiatives. This is a great example of a multidisciplinary and integrated approach. When we use epidemiological data to really understand the phenomenon and also to target high-risk areas and groups, when we use public health campaigns to raise awareness. So all types of public health initiatives tend to have a multidisciplinary focus, gaining from or taking information from the scientific field and the data, and also applying it to raise awareness and create resources and connect resources where available. Education in general, the education field is a good example also of a multidisciplinary approach, with school-based programs we teach children body autonomy, safety, safe and unsafe touches, and personal boundaries, as well as teacher training programs that help educators recognize signs of abuse. This is actually one of the applications that Eliza is focusing on a lot, and we're going to talk about it a little bit later. Legal and policy interventions. The legal field, by enacting and enforcing policies and laws that protect children and support families, improving child welfare system, ensuring perpetrators are held accountable, and developing policies that support at-risk families, as well as restorative justice. All these are components that can be very effective when we integrate them to an overall multidisciplinary approach. Definitely the medical community. We're going to hear from our medical team right after at the end of my presentation on how pediatricians and healthcare workers should receive training in identifying signs of abuse and neglect, and use that training even in regular medical checkups that can be a first line of detection quite often. Of course, social workers and the field of counseling and psychotherapy therapists and social workers can provide a lot of support, both for victims, but also for at-risk families and children, connecting them to resources and providing therapeutic interventions when necessary. Community programs that are linked to this type of work that provide resources like parenting classes, support groups, respite care services. Really, by supporting parents, the risk of abuse can be reduced, and we know that through a number of different studies around the world. Research and data, I should probably have put that first in my list. Being an academic and a practitioner, I have learned that you start with data, you always start with data, and presenting at different places around the world on the issues of child protection, this topic comes up again and again, how the research and the data is not really always incorporated into the different efforts. And that the truth is, if you don't have the data, you can't really go for policy, you can't really implement programs. So you have to start by really showing what happens, how many victims, what is the phenomenon, where can you intervene. We need the research data, and so incorporating that into a multidisciplinary approach becomes imperative. The findings from research can very much inform practices and policies. Law enforcement training, again, I'm going to refer to that a little bit later on in my presentation, because this is one of the projects that we did with Eliza. Police officers and first responders in general should be trained to recognize and appropriately respond to instances of child abuse. The role is very crucial, especially when we talk about immediate intervention and ensuring child safety, and including them into a multidisciplinary approach can be very beneficial. Now, this is one of my personal goals, I guess, for the future, tackling the media. So including the media into this approach seems to be very important. Media campaigns are integral part of coordinated responses. Media can play a very important role in raising awareness, in changing societal norms, really, and presenting information about available resources if used correctly. And I'm putting a big if there. We're going to talk about this a little bit later as well. Cultural initiatives, that's another thing that we often neglect to incorporate into integrated efforts. So cultural and also I would say faith-based initiatives. If you engage cultural and faith leaders to discuss child rights and child protection, you actually gain a lot in terms of accessing different parts of society. Sometimes child abuse can be perpetrated or actually hidden due to cultural or religious belief. So these collaborative efforts in communities can address this by including cultural and faith leaders in initiatives like that. And definitely technology, the use of technology to monitor, report, and prevent abuse is of utmost importance. You know, apps and platforms can be created for even for anonymous reporting and resource location or even educational program. And again, at Eliza, we're working a lot on incorporating technology. And actually, we're trying to move a lot of our initiatives to a more technology-based approach so that we can address more people everywhere in Greece and hopefully around the world as well. And last but not least, children. You know, incorporating child participation into integrated efforts is of utmost importance. It is a directive actually from the UN that children should be engaged in the discourse about their rights and their safety. We have to listen to their concerns, empower them to voice any issue they may be facing, and incorporate that into our preventive efforts. So if we actually take all these different stakeholders and take the valuable, knowledge and approach that each and every of this sector has, we can really create a much better prevention and intervention approach to child safety. And the value of such collaborations is not only substantial but also very multifaceted. And what we see is that when all those different sectors collaborate and we engage them at the same time, you get really a much more enhanced detection and early intervention. You get different professionals that may identify different signs of abuse that others may actually overlook simply because they have a unique interaction with a child and they miss a whole component of what may be happening in a child's life. Educators and healthcare providers and social workers are often positioned in such a way that they can notice very early signs of abuse and neglect, and that could lead to either prevention or quicker interventions. You also get a much more comprehensive assessment. Obviously, you get a holistic understanding of a child's need. All the needs are more accurately assessed, and you engage professionals from different disciplines to contribute their expertise and also identify and evaluate risk factors and protective factors in a child's life, allowing for a much more nuanced approach to prevention. You do get obviously integrated care and support through coordinated responses with all, when all relevant parties work together, the response to abuse is much more coordinated and less fragmented. Fragmentation is a major issue. I mentioned it before. I can definitely speak for Greece. This is for me, the main issue that we're dealing with when we try to create or enhance or fortify our child protection system. The child protection system that we have right now is so fragmented that when you suspect the case, at the point, when you first report the case or suspicion of a case of abuse, you may have anywhere from 6 to 8 different agencies and ministries involved with that case. You can imagine how such fragmentation really leads to losing cases and not providing the best available service to this child or to their family. And, again, through a collaborative approach, you also get better family support. Multidisciplinary approaches include supporting the family unit as a whole, addressing issues such as substance abuse in the family, mental health issues in the family, and also socioeconomic challenges. So that becomes, an integral part of the response. Research and policy development. So I mentioned that before, data collection and analysis, a multidisciplinary approach facilitates much more comprehensive data collection and also creates a much more informed, policymaking. And then I think I skipped one, education and training. I'm going to talk about that extensively through the work of Eliza, but cross-training between professionals is one of the gains of a multidisciplinary approach. We learn from each other when we work together. We gain insights into recognizing how to handle abuse and how to really recognize signs that we might otherwise miss. And under that, I would also put community education. The combined efforts of different professionals leads to much more effective community education programs about prevention and reporting of abuse. I'm gonna, I think, skip a couple of those. I'm a bit aware of the time. I want to get into the work that we're doing, but I also want to mention systemic change and sustainability. When you have collaborations, child protection gets embedded into much wider context of social systems. And, it does require systemic change to be effective. So when we work, from different perspectives, that becomes even more possible. And also multidisciplinary work promotes sustainable approaches to prevention and, ensures that efforts continue over time through, the training, again, the collaboration from different sectors. And, last but not least, I want to mention, this continuing learning and improvement that exists in collaborations where there's usually a feedback loop. Multidisciplinary teams can provide feedback to each other, leading to this continuous improvement of practices. Now, for all of the above, I just want to say that at least at Eliza, we usually follow this path in creating our multidisciplinary teams. We design, we definitely evaluate, we'll listen to the feedback, we get the feedback from the different sectors, and then we adjust. And we follow that path, or that pattern, I should say, for all our programs, so that we can make sure that the application of, what we want to ensure in terms of safety of children is something that is sustainable, and it keeps improving. It keeps improving in terms of quality and in terms of providing service. I think I'm gonna, I'm sorry. This I mentioned already, okay, in terms of sustainable application. So I'm going to move on to the work that Eliza is doing. But before I do that, I want to give a snapshot of the child protection system in Greece. I think it's important to put our work in context because, as I said before, I saw people joining the webinar from many different parts of the world. And I'm sure there are many differences in terms of how child protection systems work around the world. So in Greece, we have things that work. Definitely the programs that Eliza is trying to implement. But here I'm highlighting the difficulties of our child protection system. There is a fragmentation that I mentioned before. But in addition to that, we have a lack of national registry for reporting and recording abuse cases. So there goes the case I made for data. We don't have data. Data is not available, at least not from a valid source. We have different sources reporting about the number of cases or suspected cases, but we don't really, to this point, have a national registry. That makes our work much more difficult in terms of coordinating a good prevention effort. There's also a lack of central agency for the coordination of social service providers in abuse cases. As I mentioned before, that's the fragmentation. Too many people involved, not really communicating with each other, not working as a team. The information gets lost. Kids get, fall through the cracks, and services are not provided in, the best way possible. Although this is improving, and I wish I had our legal expert with us today, there's still issues with the legal frame of reference that we have in terms of abuse cases. That tends to impact even more the prevention efforts. Overall, understaffed social service agencies, definitely lack of training for professionals working with children. It may come as a surprise from people coming from some countries, not from others. But the truth is that we don't have mandated reporters in Greece, except for educators that, our law says that educators working in private or public sectors are mandated reporters for suspected cases of child abuse. No other professional is actually mandated to even get training. So that's a definite, stakeholder in a system. And this is something that Eliza has focused on a lot because we saw this gap in this, prevention effort to create a really sound child protection system. And we started doing work in that, targeting this lack of training. And I just want to introduce that as well. That's for further discussion, but it's one of the things that creates a lot of difficulties in creating a sound system again. So there's a lack of a foster care system. Greece works primarily with institutionalized care for suspected abuse cases or abuse cases in general. When children are removed, they're usually placed in institutions. We don't have a foster care system. We're working hard into collecting data to start creating policies and enforce the creation of a foster care system, but then we're not there yet. So this gives you a picture of what is happening and what is the child protection scene in Greece. Let's go and start talking about what we're doing as an NGO. So Eliza, the Society for Prevention of Cruelty to Children, is a highly specialized NGO. It was established in 2008 with the purpose of protecting children who have suffered or are in danger of suffering abuse or neglect. Our activities follow the multidisciplinary approach that I have been talking about so far, and they focus on prevention, detection, rehabilitation of abused children, and on the training and support of professionals. I like to categorize all our different activities in four main pillars. So there is capacity building and empowerment of professionals working with children. We do that, as we'll discuss in a second, through specialized training courses and the helpline for professionals that we have established. The other pillar is the sexual abuse prevention training for schools. We started with a great program that I will present in a moment, and we targeted children kindergarten through third grade, so 5 to 9 years of age. We're working on developing programs for kids in the last years of grade school and also high school. The third pillar is family support. So we work through specialized publication and the delivery of specialized publications for parents, as well as webinar series. We have a very extensive webinar series, a yearly one that I will discuss again in a little bit, trying to provide family support. And then last but not least, different awareness initiatives, nationwide prevention campaigns, digital information platforms, where information is uploaded for people to have access from different sectors of different stakeholders. So if you look at it, altogether, it is by definition a multidisciplinary design. And let's go into details and see what kind of applications we have managed to do that. That's an earlier slide, but I just wanted to put it there because I know it's always at least it impresses me. The numbers are probably higher than what you see. It gives you an idea of how we try to really approach all different stakeholders in the child protection area. So we're talking to health professionals, to families, to children, to educators, to police personnel, to judges and prosecutors, and obviously to children and parents. So I just had to put that in there just to show you that our efforts are really directed towards everyone involved in child protection. So I'm going to start with our webinar series. We have monthly webinars for all stakeholders. So parents, teachers, healthcare professionals, lawyers, preschool workers, police officers, social workers. We do see a steady increase in the attendance. Our last webinar took place about a month ago. It was addressing educators, teachers, if I'm not mistaken. And the topics include, abuse recognition and reporting, school violence, technology dangers and online abuse, and how you handle abuse disclosures. So on our last webinars, I think we had about 1,500 educators signing in and attending it, which is great news for us because it means that the message is getting out there and people are actually looking for information and looking to get educated and learn more about the phenomenon and be equipped on how to handle it as well. So this happens on a monthly basis, again, from different professionals. Most of the times we try to have a psychological perspective, a legal perspective, a medical perspective, and a social worker also in there, talking to all different stakeholder groups and trying to address their concerns as well as giving them information and guidance. Our Safe Touches program, my personal pride. I was the primary investigator for that program. It ran for 6 years. It's the first empirically validated program for prevention of sexual abuse in children. So it targets children 5 to 9 years of age. We started with in-person delivery. We went to many schools around the country, reached a very high number of children, and we evaluated our approach in terms of knowledge gains. So it was empirically validated for its effectiveness in terms of increasing knowledge for students. We also trained other stakeholders. So our program, and I'm going to mention that, I'm going to show you a slide in a second, included also a parenting workshop and a teacher's workshop. So we trained and we also evaluated those. Our data look really good, as you will see, which is why it was adopted by the Ministry of Education at the conclusion of our work. And the conclusion also meant that we took all this information and this great program, and we transferred it to a digital form. And that digital form, actually, it's the one that was adopted by the Minister of Education, so that now every teacher in Greece has the opportunity. It's not required, it's still an option, it's still an elective, but has the opportunity to implement this sexual abuse prevention program in their class on their own. So it's a school-based sexual abuse prevention program. It includes, as I said, a teacher workshop. It is really, it's a short commitment, if I'm allowed to say that, in terms of the teacher and the classroom. It's really a 40 to 50-minute interactive workshop. And despite that, the data looks great in terms of increasing knowledge. It also includes a parent workshop. We use puppets to help children learn. This is a program that was initially developed by ISPCAN in 2007 in New York. They gave us the knowledge. We adapted the whole program into the Greek language and culture in 2016. And then eventually that culminated last year into a 30-minute digital interactive workshop that we evaluated as well for its effectiveness in increasing knowledge. Here's how it looks when we tested kids' knowledge before the workshop and after. Kindergarten, first grade, second and third grade. This is the in-person delivery knowledge gains. The blue one is prior to the workshop. The red one is after the workshop in terms of knowledge on how to protect your body, how to differentiate between a safe and an unsafe touch, who you can talk to if you feel uncomfortable, when somebody touches you in a way that it makes you feel uncomfortable, and also how to talk to engage adults into talking about your concerns, and how to distinguish also safe from unsafe secrets. And this is the data for the digital delivery, which is also pretty good, both for younger and for older third graders. So I just want to add, because I don't have a slide to that, in addition to knowledge gains, we also went back a year later after the first delivery of the program and assessed skills gains. So we went to the students that attended the program a year before, and we gave them possible scenarios of safe and unsafe touches. And the data look really good there as well. So I keep referring to the data because there is a lot of information out there and a lot of interventions out there. But the truth is that we need to stick with evidence-based if we're really going to make a difference in helping children and providing them with helpful tools, children and professional. Okay, our other application, and I'm very mindful of time, so I'm going to speed up as much as I can, is the hotline that we established for professionals. It's been running for years, very proud of it. It's the only helpline that is available for professionals to provide assistance, psychological support, and legal counseling when they suspect a case of child abuse. We had over 300 calls for the first year, which I think is pretty good, given that we have long periods of times of vacation where the country is actually not operative. Just kidding. That people are out of schools, but the majority of our callers were from the education sector. But we're really working hard to promote the helpline to other professional groups as well, because there are a number of different professionals that engage with children, interact with children, that may see something or suspect something, and it will be great if they have the support through our helplines to figure out whether this is a reportable case or not. The majority of the callers, when we look at the first year, were people that were directly involved with the alert victim in a professional capacity. So this is saying that we're actually working towards the right direction. And again, this is an example of a multidisciplinary approach, because we have both social workers and psychologists working at the helpline, but there's also legal counseling available if anyone needs it in order to deal with a case and report a case. Back to the media. So Eliza is also doing a number of media campaigns. Here are two examples from previous years. The one has to do with our helpline. You see the number 10454. This is our helpline for Greece. So this was one of the media campaigns that is coupled with raising awareness events about child abuse. And also the other one is for World Child Abuse Prevention Day. So about a year ago from today, again, trying to raise awareness for the phenomenon of child abuse through different means. Now, in terms of future direction, I want to close with that. This is how we envision we're going to reach out to even more professional groups and engage them into helping with the prevention of child abuse. So working with and for the press, trying to prevent both re-victimization, because unfortunately the way that the press is working very often, instead of helping, it's actually re-victimizing. So our goal is to train professionals in the media field to both help the cause and raise awareness, change, as I mentioned before, maybe societal norms, but also prevent re-victimization. Another program that we're in the process of designing is the training of sports coaches in different levels of athletes. So we're starting with just younger kids that participate in sports, and we're planning to expand that even to elite athletes, training coaches to recognize and report abuse, but also to prevent abuse. Not only prevent by intervening, but also prevent abuse by recognizing how their practices may be abusive. Unfortunately, in the field of sports, there is a lot of normalization of abusive practices. So that's definitely something that we're going to be targeting in these programs. And then different programs to support high-risk families. I think the presenters right after me are going to talk about that as well. Identifying high-risk families, identifying risk factors, and really working preventively to support them so as to minimize the chances for neglect and abuse. Okay, so I think I'm right on time. Quickly, key takeaways, we can discuss them later. How significant is the creation of multidisciplinary collaborations to tackle child abuse? How these collaborations also need to have clear roles and responsibilities so that everybody contributes and everybody learns from each other, keeping in mind the team dynamics and that communication, which is very important so that we don't have a fragmented approach to all our programs. Taking theory into practical applications that are sustainable, and use the feedback from the team, use the feedback from the field to continuously improve our approaches. Thank you very much. I'm going to hand over to Dr. Soldatou. You heard her CV earlier. She is the director of one of our first medical units created in Greece for child protection. So she's going to give you an overview of the work that we do there. And I'm going to take my slides off the screen and welcome Dr. Alexandra Soldatou to follow up. Okay.
Thank you, Tina, for the kind introduction. Hello, everybody, from Alexandroupoli in Greece. That's a city in the northern part of Greece. My presentation is about building hospital-based child safety care units from protection to prevention. And I will focus on international collaboration, which I think was a key to succeed in Greece. Let's go through the topics we will be discussing during the next few minutes. I will describe Greece's starting point, how we tried to engage a strong and committed core international team, how we developed and implemented strategy, the value of international experiences and continued support by international partners, how we developed and replicated a child safety care model, and how we moved on to prevention. Prior to our interventions, child abuse and neglect was simply ignored at our hospital. When the problem became too severe to ignore, hospital staff would treat it like a hot potato, trying to avoid any involvement. This slide illustrates how a committed international team was gathered. 8 years ago, Eliza formed a strong partnership with my department at the University of Athens Medical School. My chair, Dr. Tsolia, invited pediatricians from all 7 medical schools in Greece. You can see the medical schools with these black dots scattered across the map of Greece. Our medical school is in the center of the map. She has wholeheartedly supported our work since the very, very beginning. Since there was no expertise in Greece at the time, Eliza and our department reached out to a US expert, Dr. Leventhal at Yale University, who you'll be listening to later on. Dr. Leventhal connected us with Dr. Rao, who was initially at the University of Iowa and subsequently at Dartmouth. He also introduced us to the members of his teams, the Yale Child Abuse Programs, and the Family Home Visiting Partnership of New Haven. You will see how we worked with these groups in the next few minutes. So child abuse and neglect cases are generally unseen, resembling an iceberg. In order to start seeing more cases below the surface of the water, we employed the following strategy: raising physician awareness, creating practical and purposeful clinical tools, and establishing an evidence-based approach tailored to our own setting. We started with raising healthcare professionals' awareness with 2 major educational campaigns that were conducted with this critical support of Eliza. One was on physical abuse, and the second one was on sexual abuse. We started the physical abuse program with a train the trainer module for 19 pediatricians who represented all 7 medical schools from across the country. This training was done in person by US experts who visited Greece at the time. 2 national campaigns followed, one in person and one virtually. The sexual abuse program also started with a train the trainer module, this time for 30 physicians of different disciplines. So it was an interdisciplinary team of physicians. At that time, virtual meetings were conducted with US experts to empower the team to move on to conduct a national campaign with virtual participants. You can see the numbers of the participants. I think this suggests the need and desire for healthcare professionals in Greece to receive training. We also developed clinical tools, including protocols and algorithms. We created posters for our emergency room and also pocket cards for healthcare professionals, our hospital staff. And we also encouraged the use of body diagrams. In the top picture, you can see the booklet of protocols our residents use and always have on hand. And on the bottom picture, you can see a pocket card that gives useful information on sexual abuse, but also reminds people of how to contact us. In 2017, I spent 3 weeks at Yale as an extern of the child abuse programs. As you can see in the picture on the right, my children enjoyed several social activities with Dr. Leventhal's family, including the celebration of 2 birthdays. The child abuse programs are also known as the DART team. DART stands for detection, assessment, referral, and treatment. This is the approach we use to create our own unique child safety care model. Our core team consists of 2 pediatricians and 1 psychologist. In the picture, you can see me in the middle. You can see Dr. Panos, the pediatrician who will be presenting right after myself on my right. And on my left, you can see Dr. Tsipa. She's a psychologist who works with us. The medical team is gathered on a case-by-case basis, depending on the child's needs. Our space was provided by our hospital and beautifully renovated with funding sought by Eliza. It offers privacy, it is child, family, and team friendly. And we strive to continue to provide, to create and provide educational modules, refine our clinical tools, and gather data for research. We also strive to provide one-stop shop family services, evaluation and care in just one visit. Our referrals have 4 main sources: hospital staff, healthcare professionals, other professionals working with children, and the police. Our main collaborators include our hospital social workers, you can see on the left, and the Department of Forensic Medicine and Toxicology, and the Pediatric and Adolescent Gynecology Department of our university. The main principles of clinical evaluation is to encourage children to get examined. We also follow an open door policy, so children can visit the unit anytime they like. They can also choose their chaperone or examiner. And of course, we always respect both children and their families. You will learn more about respect from Dr. Leventhal in the closing remarks. A good thing about working at the hospital is that we can provide laboratory and investigations and care on the spot. We take advantage of the hospital laboratories, radiology department for any necessary imaging, referral to any pediatric subspecialist. We also can collect forensic evidence if necessary, provide community connections, provide treatment, and of course, we never neglect family support and giving future safety tips. So we have acted as a hub at the Children's Hospital of Athens. We were the first unit, but since then, we have 3 additional units, 1 in Athens at Attikon Hospital, and 2 in the northern part of Greece, Alexandroupolis and Thessaloniki. And actually the space for the Alexandroupolis unit was just inaugurated today, so I'm very happy about that. We also tried to collect data. We used practical tools. You can see one on your screen that are user-friendly, easy to complete. And we have shared this data collection form with colleagues from all 7 medical schools so we can have a shared database. But after creating a child safety care model would not make sense without prevention. And that's why I sought and was awarded a Fulbright scholarship to visit Yale in 2022. This time I had 2 hosts, both Dr. Leventhal and Dr. Asnes, you can see on in the pictures on your screen. And what I tried to study is how to integrate home visiting programs into local health infrastructures. And we concluded that it's necessary to explore existing local home visiting programs because they might be very important partners in your effort. You should consider the local workforce, determine, of course, the training need of the prospective staff, consider potential sources of referrals for recruitment, integrate catchment area characteristics in program design, and identify widespread factors affecting the target population. In the bottom picture, you can see my children all grown up. This time, they participated in both day and weekend camps that included very fun activities, just like canoeing. So the keys to build a new model is to identify and utilize your local resources. All settings have strengths. You need to assess those and, of course, assess and address the needs. If needed, you should just seek help from experts. There are experts abroad that are very willing to help. It's important to get international firsthand experience because it changes the way you think. It's definitely different to hear something in theory and different to see it happening. You should adapt what you learn to your own unique setting. And of course, using your model as a stepping stone for prevention is crucial. So now I will move on to my colleague, Dr. Panos. He works with me at the Child Safety Care Unit, and he will be presenting some very interesting cases that illustrate the way we changed working in the setting of the unit. Dr. Panos.
Thank you, Alexandra, for passing the baton to me. And thank you, everybody, for attending this webinar. I'll now present two cases that illustrate our practice, and I hope will offer you insights on key barriers and facilitators during healthcare encounters in child abuse pediatrics. We ask for your participation, so there will be online polling during this presentation, and the goal is just to help us understand how introducing a child safety care model changed the management of two clinical scenarios in our setting, as I said. Just remember, there are no right or wrong answers. Answers might depend on your own barriers and facilitators, and all of our scenarios have been altered in accordance to data protection for our patients. So let's start with the first clinical scenario, which I have titled Panic on the Kitchen Counter. So this scenario involves a very small baby, a 2-month-old girl, who arrived with her parents at our emergency pediatric department very late at night. She was welcomed and evaluated by a pediatric surgery resident because there was a fresh splash burn on the chest and upper arm. The wound was treated and the family was given burn care instructions, and a follow-up appointment was booked for them 48 hours later. So the first question that I want to ask all of you is, should suspicion for non-accidental injury have been raised at this point? What do you think? And I'll just launch the poll for everyone. You can now see the options, and I think that I see already people are making their choices. A lot of people are voting. This is an easy question, I think, as an introduction on the polling methodology. I'll just wait a few seconds more so you all get a chance to voice your concerns and your ideas through this poll. Okay, so I see already most of you have already made a choice, and I'll show you the results. And most of you, of course, selected yes, that this was an opportunity for a child abuse evaluation to happen that maybe was lost. So let's continue. And now there's a second question for you. Which of the following do you think was the most important barrier to detect possible abuse in our case? Do you think that it was the lack of a screening tool used by the doctors and nurses? Do you think that it was lack of awareness on the side of physicians and nurses working at our emergency departments? Do you think that there was a poor connection between key colleagues working at the emergency departments? Do you think that overcrowding of an emergency room at a big hospital is a barrier to detecting possible abuse? Or do you think that the health professional that evaluated this child possibly was burnout and missed the opportunity to detect? Let's see what you think. You can now see the possible answers on your screen, I think. And yes, I see that a lot of people are voting again, and I will give everyone a few seconds to be able to log in their answer. We are a diverse crowd tonight, and remember, there are no right answers. So try to think of your own setting and try to think of what might happen in your own setting and choose an answer. A lot of people have already voted. I will just give 1 or 2 seconds more for more people to get the chance to vote. I'm so happy to see so many people participating in the poll and giving us their ideas about what is going on, which are the barriers. So, okay, I see a lot of people have voted. I'll end the poll so I can share the results with you. And most people think that the most important barrier was lack of awareness on the side of physicians and nurses, but I can see that the answers are spread through all 5 answers. And I agree with you that probably all those factors played a role in missing the opportunity to screen for possible abuse. Let's go on with our presentation. So what happened? They came to the 48-hour later appointment. They were just evaluated by surgery again, and the wound was changed and inspected. But then a week later, they came back because the parents noticed that the infant was not moving its left arm well on the same side as the burn was. The baby was fussy during the past days, but it got worse during the night that they visited us for the second time. But this fussiness was mostly attributed to the burn. This time, the nurse that welcomed them at the emergency department did her screening tool, a tool that we use our emergency department often. And this second visit, along with the seriousness of the injury that the baby had and its very young age, raised an alert with her. So she sent the baby for an orthopedics evaluation because the baby was not moving its arm well, and she thought that an orthopedic should evaluate that. And the orthopedics did an X-ray, which revealed a healing diaphyseal clavicle fracture. That's a broken bone here in the clavicle, in the neck. You can see it here marked with the arrow. After they realized that there was a fracture, the orthopedics immediately requested for a pediatric evaluation because it's in their protocol whenever there is a fracture to immediately notify pediatricians. And our protocol for child abuse screening involves pediatrics always notifying a child safety care physician who is always on call on the telephone line to review the case with them. So both of them, the general pediatrician and the child abuse specialists, established that there is need for further physical workup for abuse in this case, and they decided to admit the baby to the hospital due to safety concerns at this point. So now, which one do you think was the most important facilitator that led to flagging this case as a possible child abuse case the second time around? Do you think that it was that the nurse used the proper nursing triage screening tool and was able to raise the alerts? Do you think that maybe posters that the nurses can use at the emergency room would raise awareness and lead to better detection? Do you think that it was the orthopedics referral to pediatrics that it was the right move in this case? Do you think that a very useful facilitator was that the pediatrician had knowledge about child protection protocols and knew to alert child abuse pediatrics? or do you think that it was a good personal connection between the pediatrician and the child abuse pediatrician that led to flagging this case? I'll launch the poll so you can all vote. I just need a minute. Now I think you can see the 5 different options on your screen and you can make your choice. Oh, a lot of people, I gave you time to think about it, so a lot of people are voting immediately. I'll just give a few more seconds for you to review the different items and choose. But remember, again, this time, maybe there is no right answer. A lot of people are voting already. So I'll just give 5 more seconds for you to log in your thoughts. Well, great, a lot of answers. So yeah, a lot of people have already answered, and I'll just show you the results. I think it's a shared one this time. There's a small percentage difference between the first and the 2 last options. And most people identify that nurses using proper triage tools and the pediatrician having knowledge and good working connection with child abuse pediatric were very good facilitators at this point. Let's go back to the presentation to see what happened. So after the child was admitted to the hospital for evaluation, the next morning, a detailed history and timeline of events was obtained by the child abuse pediatrician in collaboration with our social workers. And what the mother explained was that on the first visit when the burn happened, what had happened was that she was preparing baby's, she was trying to prepare the baby's formula on the kitchen. She was boiling water on the stove in a saucepan like the one that you see in the picture. And at the same time, she had placed the baby's seats like the one that you see in the picture. She had placed that with the baby inside and the seat belts locked on the kitchen counter. But the baby was crying a lot and creating noise. So she absentmindedly, holding the saucepan with the hot water, went on the baby's direction to see what was happening with the baby. But as the baby was moving a lot, she splashed some of the water that she was holding on her right arm, so above the left side of the baby. She splashed the baby with hot water. She then panicked and tried to release the baby from the seat, but as the seat was locked, it required a lot of effort. She also called for her husband, and as they both panicking to lift the baby off the seat, they could have injured the baby. Although we had a very detailed history and timeline of what happened at that moment, we decided to have a skeletal survey of the baby. This is to inspect all the bones of the body with x-rays to make sure that there are no other fractures or older fractures, and this came negative in our case. We decided to do also a more general workup, which came back otherwise normal. And since there was no explanation other than the accidental injury that the mother described due to lots of commotions on the day of the burn, we decided to, due to the severity of the injury and the concerns for neglectful behavior on the side of the mother and the father, the family, to file a report on local child protection services so they can receive community services and secure resources for this family. Other than that, regular routine pediatric care was booked at our child safety care units. So to sum up this first case, I think the theme of this first clinical scenario was barriers and facilitators in detecting child abuse. And I think we all were able to understand that the key facilitators identified was raising awareness in our institution between physicians and nurses, using proper screening tools like the nurse did, and establishing protocols for safeguarding of children. So I'll pass the baton back to Alexandra to see how implementing those changes works in our institution. Alexandra, back to you.
So detection seems to work. It did work in our situation. Here you can see two graphs describing the increased number of inpatients evaluated for all causes of abuse. We started with about 9 patients a year, and in 2021 and 2022, we had over 50. The second graph shows you on the right, shows you the length of hospitalization in days. It took over a month for a child to get evaluated as an inpatient for potential abuse. And now it takes just about a week. Back to you, Alexandra, for the next case.
Thank you so much, Alexandra. And now we'll get our second case, which I like to call helicopter mom and just a plain team. Helicopter mom is a mom that hovers over its child like a helicopter and waits for the right moment to intervene. So let's see what happened in this case. This case involves a small 4-year-old toddler living in a remote island here in Greece, that during bath time with his mommy, he told her that a neighbor of theirs touched his penis with a plumber's tool, like the ones that you can see in the picture below, earlier that day. Mom, her first move was to examine and observe the child's body, and she did not observe any redness or any swelling or any kind of wound in his genitalia. She was very worried about the disclosure that the boy made, and she considered that a significant disclosure. So she went around to her community and asked the boy's teacher if she had observed anything wrong with her child during the past days. And she also went to her local police officer for advice. Local police officer advised her that she should report this event so they can further investigate what had happened. But the mother decided not to officially report because she wanted further validation that something had happened to her child. And she immediately took a plane from her remote island to a tertiary hospital emergency room here in the capital of Greece, in Athens. Here, she was welcomed by a physician, a pediatrician, who, since the boy had no physical findings, decided to order an immediate psychiatric evaluation of the child. The psychiatrist believed that this is not the right moment at a busy emergency department to have a proper psychiatric assessment. So he referred the child back to pediatrics, and they advised that the child be admitted to the hospital for further investigation and probably a psychiatric assessment later. But the mom refused the hospital admission at this point, and she decided to finally report the event by herself. So now it's time for our fourth question, and which you believe were the barriers to addressing this child's disclosure at this moment. I'll just launch the poll immediately, so you can vote. Okay, you are able to see the answers and vote on them right now. I'll just read through them. Do you think that the key barrier was poor understanding of local child protection system by the two physicians at the emergency department, the mother, the teacher, and the police officer in the islands? Do you think that a key barrier was the mother's hurried decision-making? Do you think that it was the overcrowding of the emergency room at that point? Or do you think that it was lack of communication between the involved physicians, or lastly, do you think that the lack of a designated child safety team at the hospital was the key barrier to addressing this disclosure? A lot of people are voting. This is a more complicated case, so I'll give you a few more seconds to go through the answers and choose your preferred answer. People are more hesitant this time around, but I think we should keep in mind that there are no right answers, and keep in mind your own setting and try to select one. Okay, so answers are spread between two possible answers this time, and I'll just share the results with you. Most people think that the most possible barrier is either the first answer or the last one, that there were poor understanding of local child protection system by those people involved, and that there was a lack of a designated child safety team at the hospital. Let's see what happened later. Okay, so after leaving the emergency department, the mother went immediately to a police station, and she reported her concerns about her child. And that police station referred the child back to us, to our child safety care units the next morning. When the child arrived here, and because we had been informed by the police by telephone before, an ad hoc team had already been formed. The evaluation was conducted jointly by a pediatrician and a forensic physician, and a child psychologist and a social worker were present at the spots. After a complete physical examination, the physicians provided reassurance to the mother that the head-to-toe assessment was normal, and they used the opportunity to offer body safety tips, and they booked a follow-up with a child psychologist. Finally, community services at the child's home were notified about the alleged perpetrator. And now it's time for our last question. Which was the most important facilitator, in your opinion, leading to improved care in the last part of this second case? Do you think that the prompt referral to the child safety care unit by the police the second time around led to better care? Do you think that the patient needs approach that was used here led to better care? Do you think that the comprehensive medical evaluation and care during a single visit constitutes improved care? Do you think that using care-focused evaluation is the best care that one can receive? Or do you think that evidence and protocol-based care is also a very, very good choice? I'll launch the poll for you. And now I think you all see the options and you can select the proper answer. A lot of people are already voting. You had time to think about this question this time also. Thank you all for voting and for participating in this polling. Your insights are really interesting to us. Okay, I'll give 1 or 2 more seconds for more people to vote. Okay. Answers are shared between choices are shared between the different answers, but I think the first one gets the most, is more favored by most, that the prompt referral to a child safety care unit is what improved care in this case. And I would agree with you that all the answers are very important facilitators to receiving better care. So collaboration works, and I think it's obvious to us that the theme of the second clinical scenario was barriers and facilitators in providing care and services in the setting of child abuse. In my opinion, key facilitators in this case that led to better care was the use of a multidisciplinary team that was available on the spot, was available at any time, and the composition was ad hoc according to patients' needs. Let's see how implementing this case works in our institution. We are back to you, Alexandra, for commenting on that.
So here you can see a graph about the number of children evaluated for possible sexual abuse at our unit. And apart from the very increased number of children evaluated, I think from what Dr. Panos suggested, you should also consider the fact that these children received much improved care. Dr. Panos.
Thank you, Alexandra. Very, very interesting. And now I would like to pass the baton to Professor John Leventhal, who is going to give us some very important remarks.
Thank you very much, Dr. Panos. I'm going to talk to you briefly today about mentoring with respect, and I'm honored to be the last speaker today. I've worked with and coached Dr. Alex Soldatu for the last 8 years, and it's certainly been an honor and a pleasure. And like a good coach, I've been both a teacher and a learner. So if I can have the next slide, I want to say that the word respect, which Alex used earlier, is a good way of summarizing our interactions over the years. There's been respect for each other's knowledge, since each of us brings his or her own knowledge, our place of work, and certainly our culture. And I think together, collaboratively, we've taken on the work with humility. Now, the word respect has 7 letters in it. I think I've got it right. And I'm going to talk about those 7 letters, but I want to remind you that I'm not the first to ever have done this. The Queen of Soul in the United States sang a song called Respect, R-E-S-P-E-C-T, Aretha Franklin, and she talks about each of the letters. Fortunately, you're not going to hear me sing today, but I'm going to tell you more about the meaning to me of each of these letters. So next slide, please. So for me, the first letter R is critical, because what's happened over the last 8 years with Alexandra, and then with Alexandros, and with Eliza as well, I've been able to provide resources. 2 slides back, please. Sorry, resources. And those resources have included knowledge, articles, regular meetings by Zoom, the introduction of colleagues and experts to provide additional advice, and then, of course, the opportunities to spend time in New Haven related to the work related to child abuse and home visiting prevention services for Alexandra, and those have been critical, I think. So there have been plenty of resources. The second letter, E, is about expertise and experience. These would, of course, be Alex's expertise and experience and mine, and it's the intersection of that expertise and experience that helps produce the clinical services and the research questions relevant to Athens and Greece, and relevant to the way that both Alexandra and Alexandros discussed their child safety unit today. Next slide, please. S is also critical. Suggestions, advice, and feedback. One cannot be a good coach or mentor without providing those. And they are critical to helping Alex, Alexandra, and Alexandros formulate and then refine their ideas and projects. And it also helps with problem solving. No project, as all of you know, all 258 of you know, moves easily and slowly and in the right direction. There's always a need for problem solving. And Alexandra and I, and Dr. Andrea Asnes, who Alex mentioned earlier, have had sessions on problem solving as we've tried to help Alex move forward. Next slide. T relates to pace and perspective. Projects always move slower than expected, especially new ones in new settings. And I'm sure that Alexandra could give us an entire lecture about that. But it's important not just to look forward, but also to appreciate what's been accomplished. Because if one doesn't take the victories and the success and appreciate them, one feels always anxious, always worried, always feeling like one's a failure, and always looking ahead. And it's important also to look back. Next slide. The second E in respect relates to encouragement, energizing, and even excitement. So I was able to create 4 E's here. Sometimes that's what is needed and what a good coach can provide. So that encouragement and energizing is so critical to an international collaboration or collaboration of any kind. Next slide. And C stands for connections. The regular meetings with me and others at Yale in Connecticut in the United States, and other kinds of connections, such as connecting Alex to the Helfer Society, the Honorary Society for Physician Leaders in the field of child abuse, which has given her connections through various talks, through the listserv on problems and how they might be solved. And finally, T, time with Alex and timeliness. I've spent a lot of time with Alex. It's been fruitful and rewarding, and importantly, enjoyable for me, and I trust for her, and both for my family and for Alex's as well, because we become friendly over this and enjoyed the work together. And I want to leave you with the T of timeliness of feedback, which is critical, essential, and keeps projects moving forward. It's not enough to wait a month to respond to a question that Alex might have. It may be important to respond the same day, the same week, and to give feedback that's timely, that's critical, that's encouraging, but also highlights where problems can be improved. So I would say that respect has been an important component of the work we've done together, and each of the letters in respect have highlighted some of the things that I've tried to accomplish over the years. I didn't realize that I was doing all this, but as I've looked back on it, this is what I've tried to accomplish, and this is what I think has been helpful about an international collaboration that started with Eliza reaching out to me in 2016 and brought us here 8 years later, thinking about this problem and sharing our experience with all of you. So thank you very much for joining us today. And I think we're done with our presentation and we have some time for questions and comments. So Jane, please take it away.
You got it. Thank you, Dr. Leventhal. Thank you to all our presenters. The case studies were really enlightening. All your presentations were so rich in content. So a sincere thank you for that. We do have questions that were being answered during the session in the Q&A. So I hope everyone has access to see those questions and the answers. I know, Tina, you were great about chatting and providing some answers. I would ask the rest of our panel as well if they have additional comments for these particular questions. And I do have a couple that came through via personally to me that I would like to also ask. And I'm throwing this out probably to Tina mainly, but to really all the panel. It says, what are the benefits of a common trauma-informed training for professionals? Like just the key benefits of common trauma-informed training.
That's a great question, Jane. Thank you. Trauma-informed approaches are definitely the thing to do right now. Everybody's trying to get trauma-informed training. And I think it's extremely important when you work in a multidisciplinary team because it creates a common basis of understanding and communication. The problem, and this was one of the questions also from one of the people attending, what are the challenges when you work with people from different fields is that very often we may have a different focus, a different priority, and different language. So creating a common basis, through all of us working in the frame that is trauma informed is definitely going to help with communication and collaboration, and obviously with approaching the subject in a way that is looking for the best interests of the people that we're serving, and especially people who are traumatized.
Okay, thank you.
Mhm.
And I'd like to kind of put a spin on that question for Alexandra and Alexandros. In the actual care units, what do you see as the real specific challenges when you bring in multidisciplinary professionals in these case studies, or in these particular cases? Sorry.
Well, I'll speak first. I don't know if Alexandra, you want to say something, but initially it might be a challenge because we might not speak a common language or might not adhere to the same principles. But what we've learned over the years is that as we work together, we get common grounds. We get used to each other. We know the way each member of the team works, and then everything just fits in its place. And I would say that our experience points to that. Everything becomes much more efficient when social workers are with us, our psychologists is with us, forensic physicians actually have changed the way they examine children. It's more of a pediatric examination rather than a forensic examination because they're just so used to how we work. So I think it just takes a collaborative effort to reach that.
Yes, I would agree with Alexandra. I think that many people have an initial barrier in working as a multidisciplinary team. They view the case from a different viewpoint. They are used to their own kind of process in working with our patients and the children that are come to our unit. But as soon as we start working together, as soon as we participate in common trainings, as soon as we set common protocols together, we immediately realize how easier our work is when we work together as our team. So the different perspective of other professionals does not make our work more difficult, but it makes easier. Everything runs so smoothly. And if I talk from my experience, by the end of the evaluation, you feel so satisfied to have done your job correctly with your team that then you can never go back in working alone.
And do you have any evidence that with this collaboration and with these units that you've been able to avoid like re-traumatization of children? Like, is there any specific evidence you have to speak to that?
Yeah, I think it's very well established, even in literature about child abuse, that conducting evaluations in one go from multiple perspectives with a multidisciplinary team on the spot, it helps avoid re-traumatization of children because they don't have to go from professional to professional and say their story again, be examined again, do different things. So working as a team also helps prevent re-victimization. And I'm sure Professor Leventhal also knows a lot about that.
You know, I think the points that Alex made are critical as we collaborated with police, with child protective service workers in the States. Exactly the same thing happened. Instead of fighting with each other, we came together and understood the other's perspectives and their needs for certain kinds of data collection, for certain ways of approaching the child, and we could accommodate them once we understood their needs and once we understood what was necessary. And then the child and the family got one-stop shopping, as Alex mentioned, and it was much more collaborative and much more helpful for the family and for the child, of course.
So a question came through, which may be appropriate for a lot of our audience in low resource areas. What happens if the faculty is missing a sector, i.e. they may not have a sexual assault examiner or forensic examiner or, any other potential professional that you've incorporated in your total, holistic approach in your care units? Like, any advice to when you're missing a sector?
Well, I think it's nearly impossible to have everything in place. There are other systems that works definitely differently. We are missing forensic interview. Forensic interview is conducted at a different institution, but we've managed to work closely with them. So it doesn't matter if you don't provide everything under the same roof, as long as you have good collaboration with somebody else who does a job at a different institution. I don't know, Alexandros, if you want to add something to that.
Yeah, I think it's important to start with what you have and do your job right, as we illustrated in our cases, with the proper tools. And once you start doing the job, other people will embrace what you're doing, and the missing parts will fill themselves. You will start identifying in the community who is good with what, and once you send up, I don't know, a kind of center of excellence, people will come running to you and support the job that you're doing. This was our experience, at least in my eyes.
So, providing that center of excellence started with the education of pediatricians at the universities and then around the country, both related to physical abuse and sexual abuse. Then starting a center at a hospital where the chair, pediatrics, was very supportive, and Eliza helped renovate a beautiful site. So, maybe there was an opening of that center where other pediatricians in the hospital started to understand what you were doing. So that was helpful. Then providing excellent care in the beginning said, oh boy, I understand. Then providing feedback to the physicians in the hospital who weren't directly doing the work. So I think all this kind of rolls along in an effective way. There were probably some problems along the way. Everything isn't smooth, but it allows this program to then be built, add to it, and then be the services it is today.
Perfect. So if you build it, they will come.
Mm.
It says, what constructs, another question, sorry, what constructs do you tend to measure in evaluation of your interventions? Like, which tools specifically? I know, Tina, you mentioned one in the Q&A. Are there any additional tools that you've used to kind of measure the effectiveness of these care units?
Well, apart from the graphs that we showed, that actually should have a denominator. So we're actually working on that. So having hospital admissions and seeing how hospital admissions went down and the cases went up. So that's one part of the evaluation. The second part is the Thomas Leventhal abuse scale that we've used to quantify the possibility of abuse in all of our cases. So that helps see that in the beginning, it was mostly children that were most possibly abused. And over time, we've moved more towards prevention with children that might have other causes and are being evaluated at our unit. So we've increased the chances for prevention with our families.
Perfect. And then there's two questions that kind of go together. One, obviously the hospitals in Greece are as busy as they are around the world. Are you able to have funding for full-time work for child safety pediatricians in what you do?
Well, our situation is a little bit different because we have a strong public health system. So Dr. Panos does not have a permanent post, but he has been able to renew his post several times to continue to work with us. And his funding is from the public. And I work at a public university, so my funding is through the public as well. But our psychologist is funded by Eliza. So we're grateful for that, because otherwise we would not be able to provide mental health care services for our families. So that's a crucial part. That's one gap that was filled by Eliza and our strong partnership over the years.
That's amazing. And then a question about training. Do you make child protection training mandatory for pediatric trainees?
Well, no. And that will be our next project. I mentioned Dr. Asnes. She is a Fulbright specialist from the United States, and she will be visiting us to work on exactly that, developing curriculum just for pediatric residents, so people who are going to become pediatricians.
But Alexandra, you should briefly mention the training for medical students, because that was interesting, unique, and you conducted some research on that.
Yes, well, we actually employed a different method to teach medical students. It's a participatory method. So the medical students themselves created a workshop to teach each other child abuse and neglect. And they've created dolls that have findings on them, medical findings. And then they do role playing. Somebody's playing the physician, the somebody's playing the parent who is bringing in the doll into the emergency room. And they have scenarios and they work on scenarios. And it's been a great success.
Oh, that's amazing. And I have a question for Dr. Leventhal. So your mentorship seems to be a critical part of this entire process, the formation of the care units. So did you feel an obligation to share your expertise, and how do we encourage more senior experts, with this wealth of knowledge, to provide mentorship and to, especially in low resource areas, and to help in the creation of similar child protective systems?
So often these partnerships that we've talked about today happen by chance. So the former director of Eliza was a guest at our child abuse program and sat in on the DART committee's weekly case review I think in the end of 2015. And then she contacted me later saying that she had a partner in Dr. Soldatu, and the director and Dr. Soldatu, had a plan to train everyone in Greece. And we said, whoa, slow down on the everyone part, but we'll be glad to participate. And I asked Dr. Resmi Oral, who Alexandra mentioned, and together, Dr. Oral and I spent time in Athens working with Eliza, working with Alexandra, and working with the pediatrician she noted in one of her early slides. So many of my colleagues in child abuse do have a calling to work to help other places. I've been fortunate enough to be selected more by chance, by someone visiting. By the way, the person, when she did visit us, we were not her first choice to visit. She wanted to visit other places at the university, which she did, but we were more collaborative with her, and she liked what she saw. And so we had a partnership that's lasted now for 8 years, and it's been a wonderful opportunity to both have Alex visit, for me to visit, and now for Dr. Andrea Asnes, who's one of my colleagues and now runs the child abuse program, to visit in Greece sometime in the future, so we can extend our collaboration, our knowledge, and our partnership.
Well, and the impact of your collaboration with all of you, the impact of children in Greece is immeasurable. So I hope you're very proud of the work that all of you have done, and the amount of collaboration and partnership that's made this come to fruition. I know that we're at time, but I did want to ask a little bit about resources. I know you had mentioned some of the programs and DART, and I know there are webinars available on Eliza's website. I'm assuming that these are all open access, and Tina, this is probably a question for you. I'm also assuming they're probably all in Greek. So if someone wanted to take the material, since you've done such great work, and translate it and make it appropriate within their own regions and in their own work, I'm assuming that's something that you would, be supportive of. So you want to maybe speak to that a moment?
Yeah, absolutely. I was just going to say that, Jane, that everything is in Greek, so it's going to be all Greek to you for those of you who don't know the language. We are going to provide access to our website and the platform for the Safe Touches program because it also has some educational material. So definitely for Greek colleagues, they can access it and download the materials. But in terms of translating either the presentations or the material that's on the website, we'll be more than happy to collaborate. So anyone who's interested, they can contact us, and we'll be more than happy to work with you on translating, validating the different language, and sharing our knowledge and expertise in that.
Thank you so much. That's a very generous offer to our audience. Well, I know we're at time. I just wanted to offer my most sincere thank you to all of you. You've been remarkable to work with, and I think the information presented is of great value to everyone who joined. And again, my sincere appreciation for your time and efforts and the great work that you're doing. And the partnership we have with Eliza continues to grow. Alina, I know that you're on, and we appreciate that partnership very much. Congratulations, Alexandra. I know that you launched your 4th care unit today, inaugurated it. So that's so exciting, and what a great added benefit to today to have that happen on the same day as the session. So thank you to everyone. A reminder, a certificate of attendance, the session recording, any resources, the presentation slides will all be sent to you in the next 24 hours to all our registrants. So thank you. A good day and good night to wherever you're at. And again, safety to everyone.
Thank you, Jane.
Bye, everyone.
Bye, everyone.
Bye.